When categorizing multiple sclerosis, our clinical framework relies heavily on the standardized phenotype descriptions that separate the disease spectrum into relapsing, remitting, and progressive pathways. For a modern, high-yield treatment strategy, we have to look entirely beyond static, historical diagnostic labels. Instead, we must dynamically characterize a patient's current disease state based on two distinct, independent clinical axes: ongoing inflammatory activity and objective neurological progression. In the relapsing-remitting spectrum, our evaluations focus on both clinically isolated syndrome, CIS, and classic relapsing-remitting multiple sclerosis, RRMS. Under this framework, both phenotypes are dichotomized strictly by their clinical and radiographic activity. A patient is classified as active if they exhibit acute clinical relapses or objective neuroimaging changes, defined specifically as gadolinium-enhancing MRI lesions or new and enlarging T2 lesions. Conversely, if a patient remains entirely free of clinical attacks and displays a stable radiological profile, they are categorized as not active. This definition emphasizes that subclinical MRI changes alone are enough to escalate a patient's classification to active, demanding an immediate reassessment of their disease-modifying therapy. When we shift our focus to progressive disease states, encompassing both primary progressive, PPMS, and secondary progressive multiple sclerosis, SPMS, the categorization transforms into a matrix of inflammatory activity combined with a distinct, independent axis of progression. This physical or cognitive progression must be determined through objective clinical evaluation conducted at least annually. This creates four highly distinct clinical profiles for progressive patients, each carrying unique therapeutic implications. Active and with progression, the patient exhibits both acute inflammatory activity, relapses or new MRI lesions, alongside an independent, steady accumulation of underlying disability. Active but without progression, characterized by localized relapses or new MRI activity, but showing a temporary plateau or stability in their baseline, non-relapsing disability. Not active and with progression. This represents the classic, insidious neurodegenerative decline, a steady accumulation of disability occurring entirely in the absence of new MRI lesions or distinct clinical relapses. Not active and without progression. This profile represents a stable progressive disease state, where the degenerative process has reached a clinical plateau and inflammatory markers remain quiet. By shifting our clinical perspective to continuously evaluate these distinct subphenotypes, we can better tailor our neuroprotective and anti-inflammatory treatment strategies to match the exact, underlying pathological behavior of the disease at any given time.